This is Deirdre Wallach, mother of free solo climber Alex Honnold, and you're listening to The Soul of Life.
Today on The Soul of Life, I speak with a doctor that is part of a handful of allergists in the U.S. that are revolutionizing the way anaphylactic food allergies are treated.
The body is recognizing something that should be harmless as a threat.
Dr. Manav Segal is an allergist based in Philadelphia to which my family owes a great debt for curing our son's debilitating allergy to dairy by offering a treatment for food allergies called Oral Immunotherapy, or OIT.
1 in 13 kids have food allergies now.
OIT has been around in the U.S. for many years now, but it is still far from being widespread among physicians who treat allergies, many of whom continue to warn their patients that a lifetime of strict avoidance is the only treatment.
The parents and patients themselves said, there has to be something more that we can do about this than just avoidance.
I speak to Dr. Segel to share how this too good to be true story could be true for your family. And we talk about why the rate of food allergies has accelerated rapidly in the last 2 decades.
The American Academy of Pediatrics and Allergy Societies speculated, well, maybe it's because we're introducing peanuts and tree nuts and milk and egg too soon, but they just got it wrong.
We talk about the budding culture shift among physicians towards widespread acceptance of OIT.
And it wasn't until about 2017 that the American Academy of Pediatrics changed their recommendations that actually early introduction is what may help slow the development of increased numbers of food allergy.
What's the latest pediatric advice about the early introduction of common food allergens to babies? What's the percentage of kids that will outgrow food allergies? And what's the difference between celiac disease, characterized by wheat intolerance, and a wheat allergy?
So if I wanted to diagnose celiac disease and I said, well, I'll do a skin test to wheat, that would be the wrong test to try and figure that out.
Welcome to The Soul of Life. I'm Keith Miller. And this is episode 14 of season 2, The Daring Doctor, Treating Food Allergies with OIT. I'm Keith Miller, and my podcast, The Soul of Life, is here to help you remember who you really are. I'll bring together people who have gotten off their treadmills. I'll have conversations with athletes, musicians, doctors, scientists, healers, and entrepreneurs to discuss the fascinating edges of our knowledge in neurobiology, psychology, and physics. This is The Soul of Life. Please take the time now to subscribe to The Soul of Life wherever you're listening. Give it a thumbs up or write a positive review. That's the best way to make sure you don't miss out on these amazing episodes planned for season 2. I'm excited to speak today with Dr. Manav Segal. He's an allergist and immunologist who treats asthma and allergies in children and adults in his Winmore and City Center, Philadelphia offices. He's the first allergist in private practice in Pennsylvania to offer oral immunotherapy, OIT, which is something we're going to speak about today in depth, in order to successfully treat food allergies, including those to milk, egg, peanut, and tree nuts, which, as I will share with you today, is a very debilitating sort of life sentence for anyone who suffers from those allergies. Dr. Segel was one of the first doctors in the region to introduce allergy cluster immunotherapy to treat seasonal allergies, which provides a faster track to well-being. He's board certified by the American Academy of Allergy, Asthma, and Immunology, and the American Board of Internal Medicine. Dr. Segel is Chief of Allergy and Immunology at Chestnut Hill Hospital and is on staff at Thomas Jefferson University Hospital and Methodist Hospital. It's my pleasure to talk to you, Dr. Segel, today. How are you?
I'm doing great, and it's good to catch up with you as well.
Likewise, it's been a while since I've seen you, and the last time I saw you, we were graduating. My son was graduating from dairy allergy treatment, OIT, oral immunotherapy, in your office in Philadelphia, which we made the 2.5-hour drive to every week, I think, sometimes twice a week, if I'm remembering correctly. I might have blocked that from my memory because it was quite an effort.
Every week and maybe every 2 weeks.
Right.
Yeah.
Right.
Yeah.
Yeah. And, we found you, this was now, I think, maybe 4 years ago that we started this treatment with you. And at the time, I remember distinctly, I was speaking with my brother about how I wish there was some sort of immunotherapy treatment like there is for seasonal allergies, for these debilitating anaphylactic food allergies that my son had had since birth to dairy and all nuts, all peanuts and tree nuts, including other things like soy. And so we, like most of your patients, I'm sure our lives as parents quickly changed once we realized he was mortally allergic. Within, he could die within a minute. We would tell babysitters just to put the fear of God in them, right? You have to tell them how to respond to these allergies, very serious allergies, which we had to live with and adapt our entire lives to and avoid those contaminants, which we'll talk about today, how that works in the body and exactly what you're doing. But when we found out about you, you're one of the few people on the East Coast. I said to my wife, I said, if he was in Maine, we would fly up there once a week if we had to. Is that life-changing of a discovery?
Sure.
And I remember first coming to your office and you just sort of explained it matter of fact, like, yeah, this is what's going to happen. In about 6 months, he'll be having real milk or something like that.
Right.
So I'm eager to talk to you about this for the benefit of others today. I'm grateful to you for really changing our life. And now our son has, of course, graduated. That was maybe at least 2 years ago with you. So he now takes a full dose of a maintenance dose of milk every day, basically a glass of milk a day, to keep his system primed and used to that. And he's also started OIT with peanuts, and he's since finished that treatment with peanuts. So now he's eating peanuts every day, drinking milk every day. We're about to start OIT for all tree nuts. So he's going to be really on his way to kind of being allergy free.
Sure.
In addition, he did seasonal allergy shots many years ago as well, which got him really off of the inhalers. So I know many parents are excited, would be very interested to hear about your perspective here. And I guess maybe can you start by talking about why you started doing this treatment and why there are so few allergists who are doing it even now?
So oral immunotherapy, you described it. It's a way to get someone who may even be highly allergic to a food less allergic to it. It's not a cure, but you can build someone's tolerance slowly, gradually, systematically over a period of time. As you pointed out, when we started oral immunotherapy in 2016, there was some small research studies at the academic institutions, but in terms of private practice doctors offering it in the region, aside from me when I started, there wasn't anyone. But you were driving up from Maryland. I don't think there was anyone in close by to you at the time. There was no one in Delaware. There was no one in South New Jersey. So I was at that time. I was serving a pretty large area. Since then, more doctors have adopted it, and it's at the time that I started, I was about one of about 70 allergists in the country who were offering it. So I had predecessors before me who kind of paved the way and taught me the ropes so that I could start offering it to my patients. And in the time frame that we're talking about, these 4 years, you've found an allergist close to you who's been able to continue that treatment. And I think that the number of allergists who are adopting this type of treatment is going to continue to grow exponentially. So it's good for parents to hear that and also recognize that while you had to make that 2.5-hour drive once a week to twice a month, nowadays people should be able to find physicians closer to home who can at least offer this type of treatment.
We're glad to see that increasing as well. Maybe for people hearing about this with food allergies, it's probably helpful for us to just start from the very beginning here.
Sure. So, basically these foods that kids are becoming allergic to, and it seems to be the same culprit foods over and over again: milk, egg, peanut, tree nut, fish, shellfish, and increasingly sesame. These foods account for 80 to 90% of food allergies. And in these cases, the body is recognizing something that should be harmless as a threat. And so it's mounting an immune response when it encounters these food proteins when they're ingested. The symptoms of an allergic reaction are pretty typical. They, can range from mild to severe. They're unpredictable, and so it's the severe reactions that we're most concerned about because they could be potentially life-threatening. The reason that they can be severe is they can cause swelling of the throat or tongue, and that can obstruct the airway. They can cause respiratory symptoms like asthma symptoms. They can cause a drop in blood pressure. Generally, the types of symptoms are itching, hives, wheezing, gastrointestinal symptoms. So you can see that you can ingest a small amount of this food protein, but you can have a pretty systemic allergic reaction that, again, in some cases could be potentially life-threatening. Mild symptoms may be, an itchy mouth or a few hives around the mouth. It'd be reasonable to use antihistamines. But when those symptoms progress to respiratory symptoms, or if we're talking about a child and they're developing hoarseness or a repetitive cough, it could be that the reaction is progressing more rapidly. And in that case, you'd want to administer epinephrine, even instead of the antihistamine. Epinephrine is just adrenaline. It's the same thing your body produces when it's stressed out. But it has some remarkable effects when we talk about allergic reactions. It stabilizes allergy cells. In an allergic reaction, airways constrict, and epinephrine acts as a bronchodilator that opens up airways. In allergic reactions, you have swelling of tissue, and epinephrine reverses that swelling by acting as a vasoconstrictor, and so helping alleviate or stop that swelling. So it does a lot of very useful things in the setting of an allergic reaction. And actually, the sooner you use it, the more effective it tends to be. Reasons we tell people to go to the emergency room if they have an allergic reaction and need to use the epinephrine has nothing to do with dangers associated with epinephrine. It is that, well, you've just had a bad allergic reaction, so you should go to the emergency room for further monitoring. That epinephrine can wear off, and sometimes those allergic symptoms can start to come back again. So that recommendation to go to the ER, sometimes people associate that with having used the epinephrine, but that's not really the reason we want people to go to the ER. We want them to go so that they can be monitored.
Another precaution, because the symptoms
Sure.
are so dangerous and can get out of control so fast.
Yes.
Right? Yeah. We had to do that once when our son was quite little, and we didn't even understand what he was exposed to. We had no idea, and this is what can be so terrifying about it, and
Right.
panic-inducing, of course, which can be a secondary type of side effect for somebody
Yes.
who lives their life with allergies, as you probably are familiar with. We still have to carry, our son still has to self-carry epinephrine for the rest of his life, even though he's undergone oral immunotherapy. Can you explain why that is the case?
Absolutely. So, people are familiar with desensitization when they think about their allergists. I mean, allergists have been offering desensitization or allergy shots as a way to treat environmental allergies, and the principles are the same. You start at a low dose of a protein, you introduce it to the body slowly and systematically, and you can build a tolerance to that protein over time. So when we talk about treating food allergies, we're using those same principles. I think it's easiest to explain it when you talk about a peanut, just because the numbers are easy. When you put a peanut on a scale, it weighs 1,000 milligrams. And when we start oral immunotherapy, we're starting doses under 1 milligram. Even the
Very
most
small.
Yeah. And the average kid who's allergic to peanuts will react around 20 milligrams of peanut protein. So our doses that we start with are below a dose that even the most highly allergic child will react to.
Mm-hmm.
But you might start with those small amounts of peanut protein and then introduce it first in the office, but have them continue that food protein at home. They'll return to our office and we'll increase the amount that we give. We may go from 1 milligram to 2 milligrams, for example. Mm-hmm. We make sure that the child's okay with 2 milligrams in the office. They'll continue 2 milligrams at home until they come back to our office, and we'll increase to 5 milligrams. If they've been okay with 2 milligrams, it's not a stretch past the body to tolerate just a little bit more. So the idea is to stay below a threshold of allergic reaction the whole time. make sure that the patient is safe when you make those dose increases, but then have them continue that dose regularly at home to maintain that tolerance until their next visit.
Right.
It takes about a year, whether we're talking about milk or peanuts or tree nuts, in the way that we've designed these protocols, to get from someone from a starting dose to a final treatment dose.
Mm-hmm.
And even once you reach those final treatment doses, the child remains allergic, but the body's been tricked to tolerate a certain amount of that protein. And so they'll continue that maintenance dose on a regular basis in order to maintain that tolerance.
Right. They could have a reaction, anaphylactic reaction at any point, even later on, and that could be somewhat unexplained, perhaps. There could be stresses on the body for other reasons that cause this flare-up, right? So this is not a try this at home. This is a do not try this at home ever.
Yes, absolutely.
And why is that? Do you get people asking you, well, why can't I just, it seems fairly simple what you're doing. Why couldn't you just give out instructions for people in the general population to do this?
The way that we've designed the protocols, we're pretty systematic about it. There's risks associated with it, as you point out, through the entire process, and even into maintenance. So these are some of the issues that continue to be monitored. There's symptoms that can develop along the way that would affect how we choose to progress. And with each of those dose increases, there's risk with each of. That seems to be the time when a person might be at greatest risk. So those are times that you'd want some sort of medical supervision and an ability to intervene if any sort of allergic reaction were to occur.
Yeah, I know we were very grateful to have your care and your supervision of this process, and like I said, we're willing to go to great lengths to do it. And tell me a little bit about the history of allergies in this country, in the U.S., and then of course I want to talk about why OIT took so long in this country to become, and is still taking a long time for it to become really widespread. There's a slow process here.
Sure. So I think one of the first trends we should recognize is that all allergic conditions have increased in prevalence in the US over a period of decades. And I don't think that the human body is necessarily making a distinction when it's primed towards allergy, whether it's tree pollen or milk or egg or peanut. And so again, all of these conditions are increasing. And typical allergic conditions are things like environmental allergies, asthma, eczema, and then food allergies falls in among those diseases as well. Over the course of decades, when I was growing up in the 70s and 80s, we didn't see a lot of kids with food allergies, but these numbers really increased dramatically.
Right. I don't remember when I was a kid, there was nobody in our class who had allergies. And now that number is what, out of 20 kids, how many are going to have some serious allergies?
So we estimate about 1 in 13 kids have food allergies, and it accounts for about 5.6 million kids in the US.
It's a huge jump, right? Over a short period of time.
When we look at the US population as a whole, about 32 million Americans have food allergies. So this is not an insignificant issue. And as we've seen this increase in numbers, one of your questions was, well, why did it take so long for oral immunotherapy to be adopted? What was the slow, uptake with this as a treatment option? The issues are that the treatment itself carried a risk. And in theory, if someone avoids the food that they're allergic to, then they don't really have to worry about an allergic reaction. But even from your own experience, depending on the food, when we're talking about foods like milk allergy or egg allergy, it's easier said than done to stay away from it, and you don't have to worry about it.
It's getting easier because restaurants are now so aware, but even 5 years ago, and still, if you visit other countries, they may say, "Oh, sure, we'll take care of that," but they're not they don't have this fear of God that I talked about earlier.
Right.
Increasingly, some do, but like you just the contamination can be anywhere in the chain.
Right. because peanut is the most common food for children to develop an allergy and remain allergic to, and the reactions can be pretty severe. So I feel like that recognition of peanut allergy is there. Yeah. When you go to a restaurant, people understand what you're talking about. They'll take precautions. But I just remember even those stories you shared with me with your son's milk allergy. I don't even know if people really understand what a milk allergy means. I mean, right. You guys used to travel and they used to, prepare stuff on the same grill as they were using butter. Yes. But I don't think it ever clicked with those people that his milk allergy meant anything, made out of milk.
Anything. And also, I want to say that there's confusion about lactose intolerance and dairy and an allergy, and they're totally different things. Right. Somebody thinks, "Oh, you're going to get a little tummy ache." Well, I'm not going to inconvenience my kitchen staff because of somebody with a tummy ache, right? And it's totally different. It's a life-threatening situation.
Yeah. So I mean, again, depending on the food that you're talking about, I think the risk associated with accidental ingestion can be very, very different. The community's understanding of that food allergy and the risk it poses, and then also the risk a patient might take and a parent might take in terms of pursuing this type of treatment, depending on what what food the child might be allergic to.
Right. And I know there's a lot of parent advocacy that's been done over the years in schools to get the awareness, the PTA level, at the administrator level, Food Allergy Network being one of them in our region. But this network of people who've gotten together and advocated and gone to state houses and said, we need emergency access to epinephrine at schools, right. At restaurants. We need Good Samaritan laws in those states after tragedies, sadly, where some administrators maybe weren't willing to administer without a doctor's order, and then there was a fatality or a tragedy. Then of course, thankfully, some of these state houses began introducing Good Samaritan laws to be able to give epinephrine on demand.
You'd asked a little bit about the history and how things progress. So we went from a period with very few children with food allergies, where maybe there wasn't a lot of interest in researching treatment options, but as the number of cases increased, and having gotten to the point where 1 in 13 kids have food allergies now, it got to a point where for parents, and now a large number of parents, to be we can do, just avoid it.
Yeah.
So I guess there was a tipping point where number of cases increased, and the parents and patients themselves said, there has to be something more that we can do about this than just avoidance.
Is there approval of this at a board level, or do you need approval of this medically to practice in this?
Doctors are cautious. Our first goal is to do no harm. Mm-hmm. And right. Inherently, just by offering this treatment and ingesting it on purpose, there's risk associated with it. So you have to balance that inherent risk associated with the treatment versus the benefits that you might achieve. I would say that things have moved pretty quickly, that now that doctors on their own started doing this independent of the larger organization, the larger organizations have now come around.
Tell me, I want to hear about your take on some of the theories about why this acceleration happened I guess we would call it an epidemic. If that's technically true, right? It is an epidemic of allergies, food allergies in this country. And is it unique to the United States? What do you think was going on in those years here in this country that could have contributed, right, to this? Do we have ideas about that?
So, the increase in allergic diseases seems to be associated with industrialization. So we see these trends more in the U.S., Western Europe, than we had in developing countries. And as these developing countries become more industrialized, we're also starting to see increases in food allergies even there. Mm-hmm. There's something called the hygiene hypothesis, which says that, if a baby's born into a sterile environment and isn't exposed to bacteria and viruses early on, that's going to affect the development of the immune system, and that could increase risk for developing allergies as a result. Increased use of antibiotics is going to affect our bacterial makeup and our microbiome. So there's many factors playing a role in the development of food allergies.
In Israel, there's this data, right? And perhaps you can speak to this, that
Sure.
because infants are given this very popular peanut snack, I guess
Sure.
they're called Bamba snacks,
Right.
and they're almost like totally peanuts, right? They're given to infants, whereas in our country, I think the American Pediatric Association in the 80s or something, maybe the 70s, started telling mothers and fathers to avoid anything a child could react to, including like honey, for example, or peanuts. And that advice could have caused, this avoidance advice could have caused the epidemic.
That would be one more factor that could account for the increase in food allergies, which is when you start introducing these food proteins. So again, genetics, the hygiene hypothesis, and then the age at which you introduce these foods. Real quick, honey is going to be a separate issue and won't be associated with food allergy. That's increased risk for botulinum toxin. So
I see.
For not giving infants and babies honey. But as far as these allergenic foods, what was already happening was we were seeing an increase in food allergies. So in order to give parents advice, well, how do you decrease this risk in development of food allergies? The American Academy of Pediatrics and Allergy Societies speculated, well, maybe it's because we're introducing peanuts and tree nuts and milk and egg too soon. But they just got it wrong. At least that's what we think now. And instead of slowing down the increase in numbers of people developing food allergies, it may have actually exacerbated the problem.
Wow.
So again, in 2000, the recommendation in terms of introducing allergenic foods was, well, don't give a kid peanuts until they're at least 3 years old. By 2008, the American Academy of Pediatrics said, we're not sure what's going on. We're still seeing increases in food allergies. And so we're not going to give any advice in terms of whether you should or shouldn't introduce foods at a certain age. And it wasn't until about 2017 that the American Academy of Pediatrics changed their recommendations based on research that had come out around that time, that actually early introduction is what may help slow the development of increased numbers of food allergies. Some of that research was based on those observations of why are we seeing increased numbers of food allergies here versus in other countries. Israel offered a nice population because we have Jewish populations here in the US that are perhaps genetically similar to Jewish populations in Israel. And we were seeing increased numbers of the development of food allergies in the US population who are genetically similar versus in Israel. And just looking culturally at what some of the differences were, peanut was peanut in the form of those Bamba snacks was something that they would give teething infants and toddlers. And so early introduction of peanut didn't seem to actually increase their risk for food allergy. It seemed to prevent the development of food allergy. So then making that observation led to, well, how do we prove that early introduction is going to prevent food allergies in this country? And so there was some pretty, groundbreaking studies published in 2015. It was called the LEAP study, which was learning early about peanut introduction. And in that study, they purposely gave kids, infants around 4 to 6 months old, who are at high risk for developing peanut allergy. They introduced them to peanut protein starting at that age. And those kids who received peanut in that very early age, even if they were at high risk for developing peanut allergy, were less likely to go on to develop a clinical peanut allergy.
Wow.
So this is where just listening to this, a parent might say, well, should I give my child peanut? You'd want to discuss it with your pediatrician in terms of when you should introduce these foods. And for high-risk infants, those who already have an underlying food allergy, maybe like egg allergy, or if they have a history of severe eczema, those might be reasons to discuss it with the pediatrician, maybe undergo testing first before you start introducing those allergenic foods. But in general, parents should be talking to their pediatrician about when can I start complementary food introduction? When can I start introducing these more allergenic foods? And the trend now is going to be earlier introduction as opposed to waiting until kids are 1, 2, or 3 years old.
Right. It's such important things to hear about, and really was such a remarkable development of reversing the advice.
Yes, I think too, Keith, listening to that too, a parent might say that they did something wrong. You might listen to this and worry, if I'd only done things differently with my child, he wouldn't have developed these food allergies. I don't think that's necessarily the case.
Please take the time now to subscribe to The Soul of Life wherever you're listening. Give it a thumbs up or write a positive review. That's the best way to make sure you don't miss out on these amazing episodes planned for season 2.
Well, it's such good news that it can be reversed, because we were really set up to, we had our hopes, Dr. Segel, that because you hear these anecdotes of people, well, maybe he'll outgrow this allergy, right? And of course that happens occasionally, right? But in our case, I think our son had reached that point, past the point of that, I think.
That's so interesting when we're talking about these food allergies, because it really depends on the food. So 80% of kids will outgrow milk and egg allergy and soy allergy, but your child was among the 20% who don't. Mm-hmm. But those statistics are flipped when we talk about peanut and tree nut allergies. So only about 20% of kids are going to outgrow a peanut or tree nut allergy. So that means that most children aren't. So even among these foods, what we see statistically isn't the same. And as we are seeing increasing numbers of children with food allergies, some of our rules of thumb are changing also. So, just as an example, when we talk about milk and egg allergy, kids are still outgrowing it, but it's taking them longer to outgrow it. So even though milk and egg tend to be foods that children will outgrow, what we statistically used to say, and the ages we used to use as a marker of outgrowing that food allergy, it's taking longer even when they do outgrow it.
Can you speak at all about I know you're not a gastroenterologist, right?
Sure.
But can you speak about, I've had a couple of guests recently, one of whom is an advocate of heirloom grains, whole grains.
Sure.
And spoke really passionately about how really we shouldn't be using industrialized typical flour, not because it's bleach, but because the flour is shelf stable, and so all of the nutrients are taken out of it, and then arguably, according to her and many other people who are passionate about this, it's caused this epidemic of celiac disease or wheat intolerance. That's a wheat allergy is different, obviously, than an intolerance, but. Right. And there's an immuno response. Can you explain the difference? Are you knowledgeable about that trend as well?
When an allergist speaks about food allergy, typically we're talking about a very specific type of reaction, but the body can react to foods in many, many different ways. So one of the first steps we talk about when we evaluate a patient because of food allergies is we're trying to establish the mechanism by which that food's causing problem. So the first is a typical food allergic reaction. So that is an IgE-mediated reaction. So again, it's a very specific way that the food's causing problem, and it's the way that we've been discussing, which is that a person ingests the food, and within 15 minutes, there's a massive systemic allergic reaction resulting in hives, wheezing, shortness of breath, those typical types of problems. People can react to food in an immunologic way that's different than that. So celiac would be a different type of immune response to a food protein. And so the symptoms are going to be different. they're not going to have those more immediate type symptoms, but they'll have a different manifestation of symptoms. But the way we would diagnose it is differently also. So if I wanted to diagnose celiac disease and I said, well, I'll do a skin test to wheat, that would be the wrong test to try and figure that out. So again, in evaluating the person, you want to understand, well, what type of symptoms brought them in? With celiac disease, it may be more along the lines of gas or bloating or abdominal pain. Weakness, they'll be anemic. They may have very characteristic chronic rashes. So again, the constellation of symptoms is different also. Right. There are also food intolerances. So a good example of a food intolerance is lactose intolerance. So in that case, a person has a pretty dramatic response to milk, but it's the milk sugar that's causing problems. But it's not an immune response. They just lack the enzyme to digest it. So when they have milk, they'll develop gas, bloating, diarrhea. In that case, again, if I did a skin test to milk, it'll come up negative, but it was the wrong test to do. So again, understanding what types of symptoms the person's having is going to lead you to help make the diagnosis and then order the right test for that person.
Tell me a little bit about how you decided to become an allergist. Did you have any personal experience with this yourself?
Sure. So, I mean, I was a very allergic kid. I had pretty bad seasonal allergies. I grew up before there was easy, even prescription non-drowsy antihistamines to kind of alleviate those symptoms. And so I suffered from them myself. Fortunately, I didn't have some of the more serious conditions associated with allergy, like severe asthma or food allergies. But even environmental allergies was enough to impact, what you do, when you do it, how you can interact and go outside, how often you get sick. And so I think I was more in tune to this as a specialty because of it. Once I got to medical school, it was something that I was interested in, and the field of immunology was something I was interested in. But by the time I got into my training, I kept a pretty open mind in terms of, the type of field I would pursue, but ended up circling back around to allergy immunology for several reasons. One of which is it's one of the few fields that you have the opportunity to treat both children and adults. And that's been a lot of fun for me. Not to be, restricted just to adults or just to kids. And it gives me the opportunity to see an entire family. And then it's only been in the last 5 to 6 years that we have started treating food allergies just in addition to the diagnosis. And so that's been a really rewarding part of my practice to be able to offer that treatment and see success with so many patients.
I can tell that it is for you, and I can tell that you delighted. And I know in our experience, my son liked to say that he was patient zero in Pennsylvania for milk desensitization.
Yeah.
Your first patient.
It's just knowing that there's a treatment option out there really lifts a weight when it becomes a matter of choice. Yes, I have this food allergy, and I choose to continue to avoid the food versus I have the option of treating it, and just knowing that they can play have some sort of conscious choice in how they want to address their food allergy. You can see the weight lifted just letting them know that option is there.
It really is. I can testify to that personally as a family, but also professionally, having treated someone who we didn't discover in her treatment of panic and anxiety for maybe almost a year of working together. It really became clear that the underlying trauma that she experienced preceding all of the panic and anxiety that she had as a young adult really went back to these hospitalizations from anaphylaxis,
right?
And the amount of hypervigilance that instilled in her,
yes,
that she could not trust her own body, that her body could attack her, that food could attack her, so to speak,
right?
And that we had to do some training and desensitization at a psychological level. So I want to shout out to other treatment professionals in psychology to flag this as an emerging, I think, category of diagnosis that we can look at, sort of some sort of post-traumatic experience that might not normally be in the patient's oral presentation or in their narrative about what things in their life have been stressful. Because as you can tell from our son, but other people, often these kids have to become very responsible very quick, which in itself is not a bad thing, but it does leave a mark, so to speak, as we like to say. It leaves a dent psychologically.
Yeah.
And it's important to catch that.
Yeah, Keith, what's really interesting too is for all of I think you'll find this interesting and you'll be able to share with me what it means. But, we have patient intake questionnaires before we offer this treatment just to get assessment of, well, how do your food allergies affect you as a parent and how do they affect your child? And so the, questions are, what's how much anxiety do you have? How much, and scale of 1 to 5, 5 being the worst. It's always level 5. What are some of the things that you worry about? Fear my child might die. 5.
Right.
With the child, what am I afraid of? Fear of dying. And when they're there talking to you, and you're just meeting and they're discussing, their medical history and their food allergies, these things aren't on the surface. It's only when you have them, they've been living with them for so long that it's not there on the surface, but it must take a real toll and a pretty deep one at that, but it's not on the surface.
Take some time and some trust in the relationship for a person to begin to sort of let their guard down and say, actually, I can, if I'm being honest, my pulse is up all the time. I wanted to, give props to our other allergist as well, Dr. Theodore Kim in Dulles, Virginia. And so for people who want to look you up as well and find you, I want to make sure people are aware of where to find you in Philadelphia and how they can reach out to you if they have questions, but also Dr. Theodore Kim as well. We can't say enough amazing things about him. And, like you, maybe it's the allergist, maybe it's because you're doing this great work and you're seeing results, right? I imagine as a physician, you want to be able to see some results. You don't want to just send people home with a plan to sort of live with, a problem, even though sometimes that's helpful for people too, to help them accept things. But, he has a great attitude also and just very happy to be doing his work. So any other things you want to say about how people can reach out to you, whether you're taking new patients for OIT?
Yeah, absolutely. I mean, we have offices in Center City, Philadelphia, and in Winmore, Pennsylvania, which is a Philadelphia suburb. Our website is philadelphia-allergy.com. And the name of our practice is Chestnut Hill Allergy and Asthma Associates. And yes, we're taking new patients and, continue to have kids finish this treatment and then have kids take their place. And in terms of, because there is a start and an end to this, which is pretty amazing to see. So we're always eager to help. And again, it's been I'm grateful to the patients too, and to you, Keith, because you trusted me early on to take care of your son. So that meant a lot to me as well.
Yeah, you're very welcome. It was our delight and our pleasure to get to know you, and super pleased to speak with you today. Dr. Manov Segel, thank you so much.
Thank you.
Thanks for listening to The Soul of Life. This is Keith Miller. Oh, and don't forget, please leave a thumbs up or a like for this episode wherever you're listening so that others like you may find the soul of life. I mean, really, it's not every day you get to share the soul of life with someone. Okay, so you can post a comment or question on souloflifeshow.com. I'd love to hear from you. And please subscribe now to get the next episode. I look forward to sharing more of my soul of life with you.
I like it and it's not harsh to my eardrum.
All right, I will go.